menstruation cycle, for which we have another foreign Professor Terapon with us. And then the management of infertility as per Pakistan perspective. So starting with our first talk, I'd like to introduce a very renowned name in Pakistan, Professor Muhammad Arshad Chohan, who's of Ops in Gynae, King Edward Medical University and Lady Willingdon Hospital, Lahore. He's Gynae and Ops College of Physicians and Surgeons of Pakistan. He's of Human Reproductive Health of Pakistan. He has some 17 research papers published on his name in both national and international journals. He's authored several textbooks of Gynae and Ops, and he's the Craft IVF Center. He has organized 3 international conferences under CRAFT, and he has attended numerous international and local conferences and courses as experts and speakers OBGY. He's speak about Luteal ART, the Lotus 1 program. Dr. Arshad. Yeah, Dr. Arshad, we can hear you. So you can start.
Bismillahirrahmanirrahim. First of all, my greetings from Pakistan. I feel sorry I could not accompany you. I wish I would have been there to enjoy the audience, ambience, and arrangements of Abbott. I would like to wish you all a happy Women's Day today. We just celebrated it at Lady Willingdon Hospital. We had a walk and we spoke about women and we supported women, and we will continue supporting women in Pakistan and globally. Thank you, Abbott, for giving me this opportunity to talk on this very important subject, because in IVF, or rather in infertility, we have made a lot of advancement, but yet we are failing in the phase of implantation, and we are working on various aspects of it, and hopefully in future we will be able to achieve the goal and we can have a continuation of pregnancy at a higher rate. I am supposed to talk about the Lotus 1 trial, but to make you understand what actually Lotus trial means, I need to go back into the luteal phase support and the other existing sports which are being compared or which are going to be compared with the dydrogesterone. What is the innovation, what is new, and what can be offered to our patients to what already exists in the market. We all understand that implantation is a complex process. It involves hypothalamus, pituitary, ovaries, and endometrium. And endometrium is specifically prepared under the influence of estrogen and progesterone. The progesterone, which is produced by the corpus luteum. And if corpus luteum does not produce enough progesterone, it may interfere with the implantation. This is what we all need to understand to learn about the luteal phase support. After ovulation, the corpus luteum is formed and it produces hormones in a way that endometrium undergoes a series of changes, and it becomes specifically receptive for the embryo, and certain structures appear in the endometrium which are called pinopodes, and you can see them here in this slide, that these are specifically made for the attachment of the embryo, and generally this implantation window appears between day 17 to 19 of the menstrual cycle. And we all have to understand that those who have delayed endometrial window formation or who have impaired endometrial window, implantation window, they all have problem in the implantation. You know what happens in the normal cycle? The progesterone is produced from the corpus luteum in a pulsatile manner, and every pulse comes in 1 to 4 hours. And those who actually conceive, the corpus luteum has a dip in the production of progesterone, which recovers instantly. But in some individuals, if it does not recover, that leads into pregnancy loss. Now, this is a very important slide. If you see the blue line, it says that just before ovulation, the progesterone starts rising and it reaches its peak on day 21. And then, if pregnancy does not occur, it starts declining from day 23. And if it declines or if it lowers down at this site, the pregnancy or implantation would not be possible. Those who conceive this progesterone line, which reaches its peak, it continues at the same level, and we have to ensure that it continues. And where we prescribe progesterone in the luteal phase, we actually are ensuring that the progesterone stays at a higher level from day 23 onwards. The other representation of same finding is that we have to maintain progesterone in the luteal phase. But what is the message for today and for you all to understand how a normal menstrual cycle differs from a stimulated cycle in case of in vitro fertilization? If you see the normal line, the progesterone rises in the luteal phase, but it does not rises as high as it does in a stimulated cycle. Number two, it stays at the same level for much longer time as compared to the stimulated cycle. That means that in a stimulated cycle, the rise is high and there is rapid fall. It does not stay on for a long time as it does in the normal cycle. And the third thing is that the fall in case of stimulated cycle is sharp. Rather, and in case of the normal cycle, the decline is slow. That's why we have to actually work on this area. Though we get higher levels of progesterones, but we have to maintain it for a longer period of time. That is the task in case of stimulated cycles. See what happens in the luteal phase insufficiency in an unstimulated cycle, and how do we detect clinically that this woman who is menstruating normally, does she have a luteal phase deficiency? Generally speaking, women who have luteal phase deficiency, they get a shorter menstrual luteal phase and they get periods 2 to 3 days earlier than the normal. There is abnormal folliculogenesis, there is defective corpus luteum formation, and there is poor support to the pregnancy. But clinically, we detected that those who develop, who get their periods 1 to 2 days earlier, they are the people who are suffering from luteal phase deficiency. Then what are the problems in the ART in addition to the natural cycle? Number one, the progesterones are produced in estrogen and progesterone, both are produced in supraphysiological levels. That's number one. Number two, the duration of ovarian steroid production in stimulated cycle is shorter by 1 to 3 days. And number three, the fall is rapid. I have already explained it in the previous cycle. That's another representation graphically. How do we look at the problems in ART? Number one, the eggs are aspirated, and when the granulosa cells are aspirated, they actually cause luteal phase disruption, and the extent of the disruption actually varies with the vigor of aspiration. Number two, the patients who undergo GnRH analog stimulation, they go through downregulation, and as a result of that downregulation, the LH suppression stays longer, approximately 10 days after discontinuation of GnRH administration. And this prolonged suppression of LH has an impact on the corpus luteum, and corpus luteal deficiency, it becomes prominent. The other things which we see in the stimulated cycle is that the stroma grows more than the glands. That's the histopathological finding in the endometrium. The endometrial preparation in stimulated cycles is not as good as in a normal natural cycle it grows in the normal natural cycle. Number two, when we do the embryo transfer, the uterine contractions set in, and sometimes they push out the embryo and they do not let it implanted at the site where it should. Those who are involved in the IVF and they do embryo transfer under ultrasound guidance, they would agree with me that once we transfer the embryo, we see that embryo actually runs up and down in the uterine cavity, in the endometrial cavity, to find the appropriate place of implantation or place where the best implantation window exists. And if uterine contractions coexist, there is a possibility that the embryo may be ejected out of the uterine cavity. And the third thing is that in case of luteal phase deficiency, the early menstruation can interfere with the implantation. That's the histopathologic, or rather the histological evidence between the two. Endometrium, I would not like to go into details, but we have to see that estrogen progesterone decline, which I already told you, that sometimes if you want to know what's the cause of luteal phase deficiency, it is the decline in estrogen and progesterone, which typically occurs 8 days after HCG administration for oocyte maturation. This happens in the patients who, the individuals who actually conceive, there is dip in the progesterone production, and that has to be recovered in patients where we want to supplement. I told you the endometrial, the implantation window appears between day 17 and 19 of the menstrual cycle. And those who have luteal phase deficiency, among them 50% have a delayed development of the endometrium by 2 days. Hence, the implantation window is shifted from 19 to 21 days. And sometimes it is not favorable for the implantation. What are the solutions? The solutions for the luteal phase deficiency are progesterone supplementation or HCG supplementation. Who told us that luteal phase support is required in patients undergoing IVF? It is under debate since the day one. And people who actually invented the procedure, they suggested that luteal phase deficiency or luteal phase support is important in continuation of pregnancy, and we should consider the luteal phase support in patients undergoing IVF. What can be offered to these patients? Progesterone, which is produced from the corpus luteum, and if corpus luteum is not giving enough progesterone, can it be given from outside? Can we make the corpus luteum to make more progesterone? That is possible through the HCG, but you will see as I go through these slides that HCG has an inherent side effect of ovarian hyperstimulation if it is used as a tool for the luteal phase support. So we are basically concentrating upon progesterone, and progesterone in what form? What will progesterone do if we make sure that there is adequate progesterone available? It actually induces the secretory transformation of the endometrium, which we all understand, and it enhances the endometrial receptivity. Number two, it causes vasodilatation, which increases blood flow through the endometrium and increases the nutrition of the conceptus. And third, we all know that progesterone causes relaxation of uterine muscles. So the contractions which are induced by the embryo transfer procedure, they are kept low, or they can be abolished with the use of adequate progesterone therapy. Hence, if we are giving progesterone, we are making the endometrium more receptive, more nutritive, and uterus is more receptive to the conceptus, and it would retain it there. Then what are the progesterone options with us? There are injectable progesterones and there are paravaginal progesterones. This is what has been established, and this is what has been worked upon before the Lotus trial. And today I'm going to tell you there is a third option which will come after these slides once I am done with the injectables and with the vaginal progesterones. The injectable is available as 50 milligram injection on daily basis, or we all know gravibenone is very popular in Pakistan. I'm sure it would be popular in Bangladesh and in Afghanistan as well, but in Pakistan, this injection is very popular and is used for very many other reasons. But in luteal phase support, it has been used as a twice weekly, or you can give 50 milligram once a day injection, which is progesterone and oil. But vaginal progesterones are crinone gel, the prometrin or utrogestrone, the third is endometrin, and these two have been compared in the literature. And before I come to the Lotus trial and give you the alternative option to the injectables and vaginals, I would like you to see how these have been compared with each other. Can we remove those slide ऊपर जो चारों काली आ रही हैं, मुझे नजर नहीं आती है स्लाइड ऊपर से, टाइटल नहीं नजर आ रहा, स्लाइड थोड़ी नीचे कर दें, इसमें मुझे ऊपर टाइटल पढ़ने में दुश्वारी हो रही है. Sorry for the interruption. We have to see that when the oral option was not available, we always had thought that these are the only two options, intramuscular and transvaginal. But today we are going to learn that there is a third option available as well. Vaginal progesterone have an advantage. They do not give higher blood levels, but they give endometrial levels which are higher where the levels are required. If you compare it with the intramuscular gives a higher blood levels and lower endometrial levels as compared to the vaginal progesterones. Therefore, and people used to say before the oral was approved, there were small studies which were saying that the oral is not effective. And this is what is Lotus study all about, to tell you what new we have got and what new data we have got to support the oral administration. Next. So, vaginal progesterones, crinone is the gel which was first used. And it has been compared with the intramuscular preparations. It adheres to the vaginal wall effectively. It is given in a dose of 90 milligrams per day, and it is equivalent to 600 milligrams of vaginal suppositories. It has a longer half-life and gives less variation between patient to patient, and but it causes local irritation. The second is endometrin. Endometrin is approved by the FDA as well. It is in the form of a tablet which turns itself into a powder which adheres to the vaginal wall, and it is said that it causes less perineal irritation as compared to crinone gel. If we compare these two, we need to see that endometrin given twice a daily has 40% results, 3 times a daily has 45% results, and crinone gel has 43. So the results of the both vaginal preparations, whether it is endometrin or it is crinone gel, the results are more or less the same. If we compare the endometrin tablet with intramuscular injections, we see that as far as significant higher clinical pregnancy rate with the intramuscular progesterone as compared to endometrin, but the continuation of pregnancy in the both cases is more or less the same. Hence, the vaginal with each other and vaginal with intramuscular have comparable results if we want to compare the two. Other study which is comparing the vaginal progesterone with the intramuscular progesterones, it says they are almost the same. If vaginal and intramuscular progesterones are found to have comparable clinical results, therefore either of the two can be used or has been used. If we compare crinone gel with intramuscular progesterone, one study shows that luteal phase supplementation with progesterone, intramuscular progesterone, has significantly higher results, 48% compared with 30%, embryo implantation 24% compared with 17%, and live birth is significantly higher in case of intramuscular. So this is another study. So there are different observations about the use of intramuscular progesterone and the vaginal progesterones. Do we need estrogen? It's very important to know that estrogen alone does not have any effect on implantation, but once given, it increases the progesterone receptors and make them more efficient, and progesterone benefit would increase if estrogen is given in combination with progesterone. The best way to have both estrogen and progesterone is to administer HCG in the luteal phase, which makes the corpus luteum to produce more and more estrogen and progesterone in a more natural way. But we all understand that HCG is associated with higher risk of OHSS, particularly in patients which are stimulated. And in that case, we are putting patients at a risk of OHSS. And those who want to use HCG as a sport, they must be very sure that they know what to do when the OHSS will occur and how they will handle the situation. Corcoran worked at, the data says that do we have benefit of estrogen? They compared progesterone alone or in combination with progesterone, and they came out by saying that where combination was used, pregnancy rate was higher and miscarriage rate went down. And many other studies have actually looked at the estradiol supplementation, particularly in patients with GnRH agonist and antagonist. The data is not very supportive in case of antagonist, but in case of agonist therapy, the estrogen supplementation has made results better in, and if you look at the slide, it says that where we used estrogen and progesterone combination, the results of pregnancy were much higher than when the progesterone was used alone, as well as the miscarriage rate was lower in case of combination of estrogen progesterone when they were used in combination. HCG, I have already expanded on it, and I tell you that HCG has better results when estrogen progesterone is produced in the natural ratio. Do we have any other option other than the estrogen and progesterone or HCG? GnRH agonist can be used in small dosage in the luteal phase for corpus luteal support. And those who have used them, they have actually shown results for the continuation of pregnancy. You can compare in a agonist trial and in the antagonist trial, the clinical implantation rate with this supplementation has been higher in both of these situations. What luteal phase protocols? When should we start luteal phase support? Generally, and I am sure those who are involved in the IVF practice would agree with me that luteal phase support is generally started the next day after egg pickup. And how do we give it? Progesterones are given vaginally or intramuscularly, I have explained. And if you want to give HCG, it is given twice a week. But we should look at the risk of OHSS. This slide is telling you that before embryo transfer, how many days before embryo transfer we should start luteal phase support. If we start 2 days before, 3 days, 4 days, 5 days, 6 days, it says that the luteal phase support started 4 to 5 days before embryo transfer generally has higher implantation rate and higher pregnancy rate. That means it should be started, oral can be started on the day of egg pickup, while the vaginal, because of the patient's comfort, is generally started the next morning after the egg pickup. Luteal phase support in the recipient cycle is also recommended and can be given, and it also can be given in a third cycle, but you have to see what we do. In case of third cycle, it is given 3 days before day 3 embryo transfer, and it is given 5 days before the 5 days embryo transfer, which is blastocyst. It's more or less the same situation as is with the day, egg pickup day. So here we do not have the egg pickup in case of third cycle. We follow the embryo transfer day, and for day 3 transfers, you actually want to do give progesterone three days before embryo transfer, and for 5 days you give it other way. The conclusion of the previous studies before we come to the Lotus trial, it says that we have enough evidence that patients who are undergoing IVF treatment should receive luteal phase support, and the luteal phase support does increase the pregnancy rate in patients who are undergoing the ART. Number 2, The luteal phase support is best initiated on the day of oocyte retrieval, but in case of the vaginal prescription, usually most of the centers are using it the next morning. The intramuscular can be used on the same day, or oral can be used on the same day. And when the Lotus trial was not available, everybody was trying to say that injectable and vaginal progesterones are the best, but Lotus trial says something different. Coming to the Lotus trial and the dydrogesterone, it says Lotus trial is a study, expanded study. I'll tell you the spectrum of this study, which has worked upon the dydrogesterone and compared with the intramuscular progesterone and vaginal progesterone. And it has come out with a news for you that it is an other uh, option available for you to treat your patients of IVF with luteal phase support with a more convenient form of medication, because intramuscular progesterone oil based is painful. It can lead to abscess formation, and vaginal is messy, causes irritation. And patients who are prescribed with the vaginal, the worries of a clinician is that how educated your patient is to put in the vaginal pessaries, the level in the vagina closer to the introitus or high up to the cervix, absorption rate, continuity. And if you compare, the oral one is more convenient for usage. If you look at the Lotus trial, see the data up to 2012 is gathered in 3 prospective studies, and it compared the 3 options of giving progesterone and dydrogesterone in 20 milligram versus 600 milligrams micronized vaginal progesterone. The results in case of dydrogesterone are better than the vaginal progesterone when it is used by 30 milligrams per day. 30 milligrams, I would like to make a point to the Pakistani audience there that when we say 3 times a day, we actually mean it should be given 8 hourly rather than morning, evening, or night. It will, if you want to have the levels constant at therapeutic level, you must give the dosage 8 hourly when we say that it should be given 3 times a day. Now, Lotus trial. It is done at 38 sites in 7 countries, which include Austria, Belgium, Finland, Germany, Israel, Russia, Spain. Simultaneously, comparing the use of 30 milligrams of dydrogesterone with 600 milligrams of micronized vaginal progesterone in the luteal phase support. And what were the objectives in this study? The objective said that we want to see the pregnancy rate, which is defined as the presence of fetal heartbeat at 12 weeks of gestation determined by transvaginal ultrasound. The second objective is that positive pregnancy test on treatment day 15 after embryo transfer, incidence of live birth, and what's the situation with the newborn was also assessed. The gender, Epcot score, weight, height, head circumference, and abnormalities in the physical examination or malformation, and the safety, tolerability, and side effects. Everything was covered in this Lotus trial. And what was the sample size? It is not a small study. It actually has 1,066 subjects upon which the study was carried out. 533 were allocated to group of dydrogesterone and other 533 were allocated to the micronized vaginal progesterone, and they both were compared in the study in the terms which I have already described. The luteal phase support with both drugs or medicines was started on day 1, which was started on the day 2 to 7 of the embryo transfer, which means that the vaginal and they were both started on day 2 of the embryo transfer, and they were given up to the 12 weeks of gestation. What was the inclusion criteria in the study? Obviously, the signed and informed consent. patients between 18 and 42 years of age, BMI between 18 and 30, and they had an infertility for more than 1 year. They were planning to have an IVF with fresh embryo, single or dual embryo transfer. These were the options which were compared. And then obviously the early follicular phase hormones were done, negative pregnancy test at down regulation, and normal transvaginal ultrasound. The exclusion criteria: who had repeated failures at IVF, repeated pregnancy failures, evidence of disease affecting the medical disorders, allergies, major surgeries, chemotherapy, radiotherapy history, and substance abuse, including alcohol, smokers, intake of other progesterone products. These patients were not, the individuals were not included in the study. And the study flow of the two groups was compared, and it was comparable on both sides. Lost number was the same, and those who did not go through the embryo transfer was 33 on this side, 22 on this side. So you will see that the individuals and were very uniformly divided into the two groups. And efficacy, if you want to see the demographic and baseline characteristics in the two groups, this is the dydrogesterone group, and this one is micronized vaginal progesterone group. The age ratio less than 35 were more or less the same, 352, 348. More than 35 were the same, almost 145, 129. Caucasian was the main population in both groups. Other races were less in number, but closer, the number were very close to both groups. The black Africans, Asians, and others were more or less the same. The BMI was very close in the both groups. And if you want to see the course of treatment, we have to see the number of subjects who underwent embryo transfer: 497 in the dydrogesterone group, 477 in the vaginal progesterone group. And if you see the ICSI procedure, they were more or less the same. Less than day 5 transfer, 350 and 328. More than 5 days is 147 and 149. Number of embryos transferred: single transfer 212, 217, double transfer 278, 252, and more than was 7 and 8. So basically the message is that were equally compared, and the numbers and characteristics were very close to each other. What were the results? We wanted to see, the Lotus trial people wanted to see that what is the result at 12 weeks of gestation with oral dydrogesterone supplementation in the luteal phase and micronized progesterone. And the conclusion was that in case of dydrogesterone and in case of micronized vaginal progesterone, the pregnancy rate was very close to each other. And these are the FAS and PPS are the two different analysis criteria. They are written down at the bottom. You can actually see if you want to see what it stands for. And these are two different analyses, and pregnancy rate are more or less the same: 37, 33, 37, 33, with a little margin to dydrogesterone. The second efficacy variable was, as I mentioned, the objectives of the study in the beginning. We want to see the number of pregnancies at 12 weeks gestation, and then we want to see the live birth rate at, we want to compare the live birth rate between the two groups and see by the both analysis, 34%, 29%, and 34 versus 29%. Again, the live birth rate is marginally higher in case of dydrogesterone. But what message was in the previous slide, that dydrogesterone is not inferior to the existing supplementation, which we call the injectables and vaginals. The overall pregnancy rate, if we want to see what is the pregnancy at 4 weeks gestation: 47 versus 45, at 8 weeks 39 versus 35, at 12 weeks 37, 33%, and live births at live birth we are 34 and 29, which means marginally better in case of dydrogesterone. Now looking at the side effects, We want to see the adverse event in the safety sample. The total adverse events in case of dydrogesterone and in case of the micronized vaginal progesterone were more or less the same. If we want to see the adverse effects by system wise, in reproductive system, the complications, the complaints, the side effects were 21% versus 18%, gastrointestinal 19 versus 17%, nervous system were 7.7 to 8.2. So the adverse effect pattern organ wise was more or less comparable with dydrogesterone. The dydrogesterone was comparable with the micronized vaginal progesterone. Infant status, it's a little more detail about the baby outcome. In case the comparison says, in case of dydrogesterone group, the total number of newborn was 213, and in case of micronized vaginal progesterone was 158. Those who favor the gender of male, they would be happy that the dydrogesterone by chance has more boys. But that is just chance. It's not a credit to dydrogesterone. The number of abnormalities or number of abnormal findings in physical examination were more or less comparable, and the other parameters of the baby were also comparable in the both groups. If we want to see the list of malformations, we actually can see that mostly the highest number is seen in the congenital familial disorders. The other abnormalities are more or less the same in the both groups, and there was no major difference. So safety profile of dydrogesterone is almost at par with the other available luteal phase supports, which is intramuscular progesterone and the intravaginal progesterone. This is the last slide, and it says that the LOTUS study was started with certain objectives. The primary objective was the LOTUS 1 demonstrated that oral dydrogesterone was non-inferior to micronized vaginal progesterone for the presence of fetal heart beat at 12 weeks gestation. So first objective achieved. Second objective was the rate of positive pregnancy test, clinical pregnancy, live birth, newborn assessment were similar between the two treatment groups. Sorry, isko wapas kaise karna? I don't know. You do it. This one. So safety and tolerability. The oral dydrogesterone had a similar safety profile to micronized vaginal progesterone with no new safety concern identified in this group. What is the take-home message? The take-home message is that oral dydrogesterone may replace micronized vaginal progesterone as the standard of care for luteal phase support in IVF, owing to the ease of oral administration. With this, I pay thank you very much, audience, for your patience listening. Thank you.
Thank you, Dr. Arshad. Now we would like to take questions as Dr. Arshad is joining us from online, and he won't be here till the session ends. So if there is a question from the audience, no, you can ask. He's listening. Or we have to take any question from Afghanistan? Okay, we have a question over here. Please introduce yourself so that he can.
I'm Dr. Hasina Sultana from Bangladesh. I have a question to Doctor. Thank you very much for your nice presentation. It was a very elaborate and excellent presentation. We enjoyed and we learned a lot. But my question is, how does estrogen helps in luteal phase defect? We know that progesterone helps, but what is the mechanism estrogen helps?
Okay.
How is?
Dr. Arshad, was the question audible to you?
Can you bring that slide back? It actually says what I wanted to say. If you
Okay.
it actually
Can we
says.
have the slides back?
I tell you what I said. I said estrogen does not have a direct role on the endometrium. It enhances the progesterone receptors in the endometrium. It increases the progesterone receptors, hence makes the available progesterone more effective. So estrogen does not have a direct effect. It acts through enhancing the progesterone receptors, making progesterone more effective.
Does this clear your query? No, I'm asking ma'am. Are you happy with the answer?
Estrogen and progesterone, they are contradictory. They cannot reside. Mechanism is different. One is antagonistic to other. So my question was, that's why I asked this question. And it increases the progesterone receptor, you have mentioned already, but my question was actually estrogen, it might increase the receptors, but it has a proliferative effect. And I'm not very clear about this. Can you throw some light again?
I will perhaps be able to explain. If we bring the initial third slide, a graph on projection, this is slide number 5. If you can bring it on projection. This slide number 5 says, in a normal cycle, there is production of progesterone in excess in the luteal phase. At the same time, there is production of estrogen. That means that in a normal cycle and normal implantation, some quantity of estrogen is required in addition to progesterone to enhance implantation. In patients undergoing IVF, where the eggs are aspirated, the granulosa cells are aspirated, hence their capacity to the capacity of corpus luteum to produce estrogen and progesterone, both are affected. Hence, primarily we need to give progesterone, but some supplementation of estrogen would be a compensation for the luteal phase insufficiency, which is caused by aspiration of the follicles in case of IVF patients. That's my reply to your question.
Okay, she's clear now. Thank you very much, Dr. Arshad. Can we have a question from Afghanistan? Mr. Shafiq, if you can hear me, and if there is any question from Afghanistan, please. So I guess there is no more question. Thank you very much, Dr. Arshad. And if we receive any more question, I'll email them to you and we'll take care of them later. Thank you very much.